Can you see us?
Yes. Let's hear about case number 13.
Case number 13, who actually presented to the outside hospital with the angina class 3, if you see here. And she has had prior multiple PCI. She has been on good medical therapy, including ticagrelor for her CAD. So in 2017, what happened is she had presented there with a STEMI slash, non-STEMI, and at that time RCA was a culprit. They took care of it, and somehow even at that time they knew that when they stented that it was underexpanded. However, she was left, this was way back in November, she was left on medical therapy. She did well and represented with the unstable angina. Instead of doing a cath there, they just sent her here. So we actually had a film that had come from outside hospital, at which time we did have her angiogram, where we saw that RCA, there was an underexpanded stent. So if you see the left system here, non-obstructive disease, but more important, we are seeing some filling of the right coronary artery. EF normal, but this is what we find today. She comes here. This is, I think, that vessel totally occluded. But can you see that underexpanded stent?
We can see very clearly.
Yeah, see that? So initially we had planned that we never thought she'll come with occluded vessel, that we will wire it with a regular wire, do an IVUS, show the underexpansion, and then do the rotational atherectomy. But it was a difficult crossing. We had to use specialty wires to cross Gaia. Again, Gaia crossed it. And the same thing, if you see here, the fine cross would not make a turn further down. We already have a 7 French guide, 7 French Godzilla. If the fine cross just stopped at that point, but changed to Rota extra support. We were able to change it to Rota extra support, and this is where we are now. So I'm just going to see if IVUS will go on the Rota extra support with the Godzilla.
Why do we need that? We already had such troubles going far. You have the wire in.
Yeah,
I don't know.
IVUS closer. So if it does not go, because of the lack of support of the wire, then we'll abort. And then the question would be the same, what should be the burst size? What do you think? 1, 2, I mean the fine cross did cross that underexpanded area.
1.5. It's difficult to judge without seeing the old film when the stent was open, underexpanded but open. Certainly shouldn't be too small, otherwise you risk.
Yeah, no, nothing goes. Don't challenge your system.
Okay.
Don't challenge your system. Yeah, start with 1.5 and hope for the best.
Okay, open the 1.5 bar quickly. Question is 1.5, 1.25, right?
1.25 tends to get trapped.
Okay, let's go 1.5. If we have trouble, then we have to downgrade it. Agree?
Yeah, 1.5 at 165,000 RPM.
So I'm taking the Godzilla out.
You taking, or you're not doing through the Godzilla? Okay.
I think 1.25 bar would have been okay, but not 1.5 bar in the Godzilla.
All right. Well, we got to get ready to go higher afterwards. What's that distal wire?
You good?
All right. Any ideas regarding bearing underexpanded
Can you get
stents?
another fellow from somewhere?
What you have done? You seem to be the point person to start again.
Come here.
Well, I mean, of course, springs to my mind the idea of using a shock wave if available.
Okay, stop.
I've not done a super convincing underexpanded stent case yet, and there is no experience in animals. However, I'm aware of at least 2 very good convincing cases done at super low pressure, which is 4 atmospheres, with just the mechanical effect of the shock wave. And I had a case where also the stent was somehow fractured before starting, so in unusual
Does he know we are here?
stenosis, result was good anyway. I think
So
that will be the way to go for the time being. However, it's not
keep
available
the IVUS in the side
in
again.
the US, so I think you should go with this conventional technique that, if done properly, works, but you need to be aware of all the possible risks, especially the trapping of the bird.
Lights down, guys.
Laser will have a role here? Laser?
Yeah, you can do as shown before with high fluency and
Well, you got to do the laser with the dye, for sure here, because you really want to create a big explosion.
Where? You're talking our room?
If we go in laser, yeah, we're talking in general here, while you're loading the rotablator. Yeah.
Okay, so we are ready with the Rota, but we, like I said, I told you we have Rota extra support wire.
The
and we have-
rotablator we're doing is been announced all over Mount Sinai right now. That's great.
Okay, let's go with the, bring it closer so I can see the speed. Okay, good.
It's fire.
And they will not stop until we're successful to burr this underexpanded stent, sounds like it.
We don't have a... Good, go. Good.
Right in here.
We don't have a pacemaker. I mean, we have a vein, we didn't put a pacemaker. Wire? Give me.
Well, wasn't the entire panel saying this morning how we don't really need a pacemaker in...
For the right coronary artery that is like this,
yeah,
You just give aminophylline.
you want to
there you
try
go.
it out?
Just give aminophylline. Start ordering from the pharmacy. Takes
Okay,
only
okay.
60 minutes to prepare it.
We can, I think it's easier.
Maybe they got to bring it from BI, yeah, that's why. Apparently they have it
We bring
right away
our
at
own
BI.
aminophylline to a lab.
Because it will be very difficult.
Sometimes a bit of atropine before starting,
Yeah,
waiting that
give
the
atropine
heart rate
before
is
you
up.
start, and we send courier to BI to get aminophylline. Dr. Hermath, what do you think? You always do a pacemaker in a rotablator or RCA?
We do, yes.
Go.
Yeah, so far 2-1, don't worry.
How often you see successful the Rota
Okay, go.
unexpanded stent? My experience, half and half. Sometimes yes, sometimes no.
Well, no, I think Rota is successful to go through.
Yeah.
But
how-
the aspect is that do you have enough lumen even after that to do an adequate
Yes, yes.
expansion of that stent or a new stent? Because, you know, that's why I said maybe in this case the vessel seems quite big, even if 1.5 goes,
Okay,
then
ready.
still it may not expand further. So you may
Going up.
want to try a 2.0. Well, obviously I don't know how that works.
Josh,
But we don't have a
ready?
good solution with a bigger one.
That's the real point which is answering your question. Would this be, how successful could you be would determine
Good.
the size of the eventual burr.
Going.
You know, if you're going to leave it just with the 1.5, then really you haven't done much. And of course, the proof is put in the IVUS before, later, and do the imaging, and we'll see.
Yeah. Well, I'll give you a measure of success. If the IVUS goes after the rotablator, that was successful.
Okay, ready? Pull back. Okay.
Let's see how it goes. Just take the rotablator and the vessel.
2.5 burr, it'll obviously go.
Okay, we are doing our 3 steps.
Just let it go in
Dyna.
a little bit. It doesn't matter, it jumps. It's a little dyna.
Okay, I'm going to go Dyna. Press here. No, press brake release.
Break on dyna.
I would have used a AL1 guide.
Okay, good. I went forward with the Dyna.
Good?
Lima is,
Makes sense.
as it is, it's already done.
Because we don't really need to burr up front. We're only aiming to burr in the
Guideline.
yeah. And let's see.
Look at, she's a pacer dependent now. You can see that?
No, not here.
No aminophylline. Back order aminophylline here.
Let's see. Make sure we burst at a high speed over there in order to
I can tell you.
burr it.
Yeah, you know the trial name? The trial was called BARD, B-A-R-D. BARD trial was done with aminophylline atropine given to these patients instead of pacemaker. But I can tell you this patient will not follow. In that also, urgent pacemaker was needed in about 12% of cases.
Right.
To advance the wire a little bit.
This is, you went 1.5 bar?
125.
125, yeah, 125.
No, 1.5. This is 1.5.
Yeah.
I know. We
This should have
started.
been a 1.25.
Okay, let's advance the wire as you're burning. And you have to go high speed, that's what we said.
Okay, good.
How high speed you go to, George?
Well, 165. I don't know what the speed is that I can't hear. What is the speed?
You have to press the brake.
It's like, you're like advance the wire means what?
Yeah.
Standing there and
Good. Let's go again.
it's a
You need more.
extra support.
It's good word, it's an extra support.
No, stop it, don't advance.
Also, what we require in the patients when you are doing an instant restenosis unexpanded, make sure you keep changing your wire position. Because if the wire is a little eccentric, we'll cut it.
No, but
So
we want
very,
to
very
change it to
important.
floppy wire. We have Rota extra support.
No, extra
Maybe it's
support is
against.
okay.
No,
Yeah.
maybe it's against. It's
Yeah.
hitting the wall.
No, but the guide, it should have been an Emplart's guide in this case. And 6 French would have been good enough. Anyway, go. Even 1.25 is not going.
This is 1.5.
Maybe get a laser machine from other room now. It's already warmed up.
Okay, let's change to 1.25, right?
Okay. Yes. Okay, we are going
No,
to the one.
what is the speed now? What is the speed? What, when you,
155.
Okay, we do 170.
155. Go to 170.
200,000.
One case we'll do
Go
170.
to 170. I say, Dr. Eastman says afterwards, go to 200.
Good.
Try to go 170 now.
Okay. Go to 170.
170 plus.
All right, 177. Good.
Good. Keep going. 177, but
No, it's just
sit on
a
it.
wire bias, lot of wire bias.
Good.
You have to change it to Rota floppy.
Do a few bearings. You only did one run. Do 3 or 4
What I'm
runs.
saying is we have to change it to Rota floppy wire. The stiff wire is against us.
Yeah.
It's just hitting the one wall
But
of
try
the
if
stent.
you-
You got to change it. Otherwise,
No,
we'll
but
cut
we are
the
coming
wire.
up. No, but let me tell you, this case should have been done with the occlusion total, should have been with a 1.25 bar. This Rota will cut the wire. Let's come out. Get 1.25 bar.
No, and change to floppy
So
wire.
let's get then the floppy wire and 1.25 burr.
Yeah.
He's pushing.
Field or fine cross first. I mean fine cross, not fine. Yeah, you can take a picture now of what it has done.
Slowly.
It has not gone through it, so that it hasn't done much. So this was very unexpanded stent before.
No, it was totally occluded.
Yeah, and now it's totally occluded. You have the guideliner still? No.
I took it out.
Yeah, okay.
Try to put a
Okay, we are going to put a
1 to 5
1.25.
high pressure.
You have the Rota floppy wire? Yeah?
So now question comes, the logistics wise, they still have 4 more key lectures.
Why don't we break and go to a couple of talks and then we come back to you? Why don't we do that? Because it looks like there is some,
Wire. Hold.
this case is going to take some time. But at least we do the first of the 2 talks.
But let's see, people want to see it versus we can still put on one side while the lecture's going on. Is that the better sense?
Yeah, I would probably go to, why don't we go to the lectures while you change and all that, and then if you,
Or you know what? Wait 1 second. Let me do this 1.25.
Yeah.
So at least we cross. Because otherwise, you know, we were the believer of this doing a Rota for unexpanded stent along with the laser.
Did you clean it? Wire.
And we had very good results. Actually, I have few cases where the laser did not open it and I needed to use a large bar. So now we have the fine cross has gone in. We take this wire out, going to change and 1.25. But just to say, with this kind of case by history, and your total occlusion now, first burst should have been a 1.25. Ready? I'm taking this wire out. Good.
Since the fine crossed the lesion, we were debating 125 or 1.5.
That's right. The occlusion seemed
Yeah.
to be a little bit more
it's
distally,
a
really. That
totally
area
different.
was not occluded.
ISR unexpanded stents behave totally different way. And as I said, that I know many times there are data now that you can, basically the diamond chips of the burr get embolized. They have seen electron microscopy, but more importantly, it is not that doing anything to the stent. It's just heating up the stent, making it very heated metal, which further liquefies the calcium behind. So actually, while we are doing now, I have another patient, and we actually we receive at least 4 or 5 patients of these kind, unexpanded stents because of large calcium. Right now, there is in another room, the LED case is there, which they are doing it. They started doing it now. Another unexpanded LED stent came from outside. Same way this case. So unexpanded stent, we all know, besides sending them for surgery, there are 2 options: do the laser, or you do the rotational atherectomy. Laser basically by vaporizing the calcium behind works. The rotablation don't work by ablating the metal. It basically just warm it up, heat it up, and subsequent dilatation of that the heated metal will liquefy the calcium behind it. The few other points which I want to make sure that you keep changing the wire position, because once in this ISR cases they are little eccentric. Good. They'll cut the wire. Very common occurrence. We actually have personally 3 cases, or the wire cut in little angulated ISRs and unexpanded stents. The burr stuck could happen, but same, you go small burr, slow, will be okay. And this is where we are now, going with a 1.25 burr. Good. That's okay. Go. Yeah. It's a 160. Go to 170.
Yeah. Let's go high speed as well, over 170. Rota floppy 125.
177.
177. We seem to be hitting the same number again.
Wow.
20 seconds, 22 seconds, 182, 24 seconds.
Tough one.
Yeah. There's a lot of wire bias, even with the rota floppy wire.
Good. And it is in the lumen, because your fine cross went very easy. So it is not that we are behind the stent struts.
Right.
The only question is the guide support.
I think go higher speed.
124, 77, 10 seconds, 175.
We can go to 180.
185 or, you know.
Okay, go to 180.
Are you sure this is connected properly?
Yeah, it is connected. Otherwise, it won't get to that speed.
I'm just solving it.
Yeah.
Okay, go.
Will not get 180. Good. 189. Good.
189, 189. Keep going, keep sit on it. It's going to go.
Don't ask me, these people did it.
Yeah, good. Making some progress.
Some progress.
Well, you need
Little
to
progress.
burn quite a bit.
Quickly put in a balloon to get.
Oh, I'm going to change the wire position again. Go. Good. You see that wire position being changed?
It's crossing. Yeah.
Yeah.
All right.
All
Went
right.
in. 190 was 190,000 RPM. Very good. With a 1.5 burr and a rota floppy wire.
Yeah, actually, when we did these cases back in late 90s, we asked David Oth, and actually Mark knows about. So David Oth said that while he did the bone experiment with the rotational atherectomy, he did it, use the rota in the metal. He said metal clearly, this rotablator will scrape the metal, but they're usually not those particles of 2 micron. They're usually more longer particle of 15, 20 microns in the length. We need to go a little further. No, we go 1.5. Okay, now what we do is still will require some more work. We are going to go back to 1.5 and you
Yeah.
can start your some lectures.
Great. Why don't we do that, and
Yeah.
you let us know to come just for the final picture. Final picture you just showed us in the next session.
Perfect.
We're going to go now and going to start up the